Hello. The topic of my presentation is point-of-care bleeding management in cardiovascular surgery. I'm a senior consultant for anesthesiology, emergency and intensive care medicine at hemostasiology and worked as a senior consultant at the Department of Anesthesiology and Intensive Care Medicine of the University Hospital of Essen in Germany for 26 years. I also chaired the section of clinical hemotherapy and hemostasis management of the German Interdisciplinary Association of Critical Care and Emergency Medicine and worked in the scientific subcommittee for transfusion and hemostasis of the European Society of Anesthesiology and was one of the authors of the first version of the ESA guidelines on the management of severe preoperative bleeding. And most important for my conflict of interest, since July 2012, I'm the Global Medical Director of TEM Innovations, which belongs to Werfen since 2016. The main question is, in patients with bleeding after cardiac surgery, why my patient is bleeding. And sometimes it's clear that it's a surgical bleeding when, for example, the blood comes up to the face of the surgeon, then it's for sure a bleeding from a high pressure area like the aorta with an open vessel. And on the right side, we have the situation with the so-called blood on floor syndrome. And then usually we have a combination of both surgical and coagulopathic bleeding. However, the question is how to fix it, and there are still different concepts around the world. One is to activate your massive transfusion protocol, which may be important to keep the patient hemodynamically stable and enough volume in the vessels. However, this is usually not the right way to stop coagulopathic bleeding, or we can activate our massive hemorrhage protocol with the aim to stop the bleed as soon as possible and to avoid massive transfusion. For this, we developed already more than 20 years ago protocols or algorithms, and they all start with the same question. Do we have a diffuse bleeding, and do we have to consider a hemostatic intervention? When the answer is yes, we go step by step through the protocol, which starts with the most important things, and then to rule out any hemostatic issue. This can start with looking at hyperthrombolysis. It's not so important in cardiac surgery because most of the time patients get tranexamic acid or MLCAR prophylactically. Then, of course, after weaning from bypass, we have to reverse the heparin effect with protamine. And here again, of course, ACT is important, but if ACT is prolonged, this can have a lot of reasons like residual heparin effect or protamine overdose. And here the in-time to heptime clotting time ratio can help us to differentiate both. The centerpiece of all algorithms is looking at clot firmness, here the amplitude after 5 minutes, in the XTEM test as well as in the FIBTEM test where we knock out the platelets. And if both are reduced, most probably we can stop the bleed by increasing the fibrinogen level, and we can even calculate the amount we need. Or we have to look for platelet issues, which we can address with a platelet contribution in clot firmness, which is a difference again between XTEM and FIBTEM clot firmness, or with additional platelet function tests. And then we look at thrombin generation, which is usually not the first issue. So therefore we correct the fibrinogen first, but if then still there's a prolongation of the clotting time and the patient is bleeding, we consider plasma or PCC to increase thrombin generation. And finally, if there's after the intervention an ongoing bleeding, usually we recheck after 10 to 15 minutes and do some fine tuning. We can also adapt the protocol to the pediatric population, which needs usually a little bit lower clot firmness. But the key message of this slide is that we understand ROTEM algorithms as not to-do algorithms. So we use the very high negative predictive value to exclude reasons for bleeding and to do a most restrictive transfusion strategy. If we go step by step through the algorithm, of course, time matters in severe bleeding because every delay in therapy can result in more blood transfusion. Again, thrombolysis management can quite easily be detected. Here we see in the middle a normal XTEM and FIBTEM. On the left side, we see that the clot firmness reaches already after 15 minutes its maximum, and then decreases quickly, and after here 25 minutes no clot is anymore detectable, and this happens even faster in the FibTEM. The opposite is the so-called thrombolysis shutdown, where we have less than 3.5% lysis within 1 hour, here 0%, and that means that even physiologic lysis is not working anymore and associated with more thromboembolic complications. Of course, a key part is heparin protamine management. Here again, we see a normal INTEM, so intrinsic activation without heparinase, and HepTEM, which is intrinsic activation with heparinase, which cleaves residual heparin. Here we see normal clotting times in both. When we look at the left side, we see that the clotting time in INTEM is much longer than in HepTEM, so it's more nearly 700 seconds, when HepTEM is less than 200 seconds. And that proves that there is residual heparin effect and the patient needs more protamine. In contrast, on the right side, we see a prolongation of both INTEM and HepTEM clotting time more than 300 seconds. And that's a typical picture of a protamine overdose. And the prolongation is due to an inhibition of factor V. And what we also know that this has a negative effect on platelet functionality. The quite good correlation between INTEM and HepTEM clotting time to anti-TNA activity we see in this Japanese study, where ACT is not really designed for low heparin concentration here, below 0.4 units per kilogram. Correlation is only 0.12. Also APT performs not well, where the INTEM to HepTEM clotting time ratio has a correlation of 0.72 to the anti-TNA activity, and help to calculate the protamine dosage needed to eliminate a residual heparin effect. Why protamine overdose really matters? This is a randomized trial from Amsterdam, and they compared a low protamine to heparin ratio, which means about 70% protamine of the primary heparin dose, where the high protamine to heparin ratio was 100% of protamine compared to the primary heparin dose. And we see that red blood cell transfusion, plasma and platelet transfusion is higher in the group with a high protamine dose. And also when we look at the incidence of the need to thoracotomy the patient, it's increased from 2 to 9% in the high protamine dose. So less can definitely be more. If we look at pediatric population, we see that the most often reason for prolonged ACT is a low fibrinogen level, because of course in the small blood volume of small children, hemodilution happens so much faster. So the key message here is protamine is not vitamin P, and the overdose definitely matters. When we move to clot firmness management, we see again in the middle a normal XTEM and FibTEM. On the left side, we see that the amplitude 5 minutes after clotting time in XTEM is reduced to 24 millimeters, which shows, yes, we have a significant problem with clot firmness. And the FibTEM can help us to discriminate, because here we see that FibTEM A5 is only 6 millimeters, which proves that the main problem is a low fibrinogen. In contrast, on the right side, we have also reduction in clot firmness in XTEM here to 29 millimeters, but FibTEM is very strong with 15 millimeters, so adding more fibrinogen will not be successful to stop the bleed. In this case, we have to consider platelet transfusion. So what's the evidence behind? It's a study from Kivan Kakuti, already 11 years old. And what he showed in this study, more than 4,600 patients, that there's a close relationship between the post-cardiopulmonary bypass fibrinogen level and the probability of the need for a transfusion of 5 or more units of red blood cells. So we see if the fibrinogen level is 0.5 gram per liter, 60% of the patient needs 5 or more units of red blood cells. If it's 1, it's still 40%. If it's 1.5, it's 22%. And if it's 2, it's about 13%. And then we see there is no further improvement by going to higher fibrinogen levels. So we can learn from this curve 2 things. First of all, if there's bleeding and the fibrinogen level is below 1.2 to 2 grams per liter, yes, it makes sense to increase the fibrinogen level, but not to a higher level than 2 to 2.5 grams per liter, because then we have a ceiling effect. The point is that we can measure this on bypass with FibTem, but it doesn't work with a closed method because then we have very high heparin concentrations. So in this study from the same group with more than 1,000 patients, it showed that again the FibTem clot firmness on bypass predict very well the fibrinogen level with the closed method after weaning from bypass with an area under the curve of 0.95. So that means, in particular in countries where you need cryoprecipitate to increase the fibrinogen level, it's of course helpful if you have already results available before you wean from bypass. This study just recently done in the US showing that ROTEM Sigma, so the fully automated system, works very well to identify a low fibrinogen level. And also when we look at the platelet contribution, in particular when we look at the difference between XTEM and FibTem, which is called the platelet contribution to clot firmness, there's a very good correlation between the PL10A5 and the platelet count below 100,000 or 75,000 or even 50,000. This also works in the pediatric population here in a study published by Marco Ranucci from Milan, showing that the situation is very similar, that also fibrinogen level below 150 milligrams per deciliter, also in the pediatric population, is a good predictive marker for postoperative bleeding. And this has been confirmed also in a randomized trial done in London by the group from Beverly Hunt, which shows again, yes, the FibTem can identify the patient with an increased bleeding risk here with a level below 7 millimeters. But also you can exactly calculate the dose needed, because we see here that the dose needed to get to 1.5 to 2.5 gram per liter is between 50 and 200 milligrams per kilogram. But with the calculated difference where you are and where we want to go, you see that in most patients with one intervention, we exactly reach the target of 1.5 to 2.5 grams per liter. This is also mentioned here in the review paper we published already in 2019, that with a targeted increase, we can quite exactly calculate the fibrinogen dose. For example, for an increase by 8 millimeters, you need 50 milligrams per kilogram body weight. That would be an adult of 80 kilograms, 4 grams, or if we use cryo, it's about 20 units of cryo in a patient with 80 kilograms. This is also mentioned in the international consensus statement from the European Association of Cardiothoracic Anesthesiologists, that they recommend, in particular in cardiovascular surgery, not to use a closed method anymore to measure the fibrinogen level. It's to use viscoelastic point of care testing for several reasons. First of all, the turnaround time is much longer with a standard fibrinogen level. Second, it's heparin sensitive, as you get wrong low results if you measure on bypass, and there's a quite high variability. Now we are moving to thrombin generation. Here we're looking at the extrinsic and intrinsic pathway, both with a heparin inhibitor, because now the question is whether there are also oral anticoagulants on board when they have different patterns. So vitamin K antagonists usually only prolong the clotting time in the extrinsic activated test, where the intrinsically activated tests are normal, where if the patient is on DOACs, here in this case dabigatran, we have a prolongation of both the extrinsic as well as the intrinsic pathway. There are several studies from already more or less 10 years ago showing that there's a very good correlation between the XTEM clotting time and the INR in patients on warfarin. Here you see the R is 0.86. This doesn't work if you use intrinsic activators like the Kaolin Tech or the Intem, and then you see the curve is very flat and correlation is much worse. So the message is you definitely need an extrinsic activator to have a good correlation to INR. This is also shown here in this study done by Annabel Blasi in Barcelona, where they were looking at patients on warfarin and had an elective heart wave replacement. So they first reversed the high INR with 4-factor PCC, and then the question was whether the INR is higher or lower than 1.5, and with a cutoff value for XTEM CT of 84 seconds, you see that there's a very good discrimination with an area under the curve of 0.998 to discriminate between INR higher or lower than 1.5. So why it's important to have a good management also in patient on direct oral anticoagulants. This is that more and more patients also emergency procedures are treated already with DOACs because of course the incidence of atrial fibrillation is in cardiac patients very high, and actually we have several strategies available. One is wait, and of course in elective cases and in urgent cases we can reverse the effect on the one hand with 4-factor PCC or with andexanet alpha. However, with andexanet alpha we have to consider that this also reverses the heparin effect. So these patients are, after the reversal, heparin resistant. We cannot use heparin anymore for anticoagulation on bypass. So therefore, in this case, proton-beam complex concentrate might be the better choice. Another possibility is if you have to do urgent or emergent cardiac surgery in a patient on a direct 10A inhibitor, we can also eliminate the drug with a cytosorb filter during cardiopulmonary bypass. And you see here that takes about 2 hours, and we can use even a tissue factor activated ROTEM assay to monitor the decrease of the plasma concentration during cardiopulmonary bypass, because these tests also have a strong heparin inhibitor. Why we should be very careful with plasma in cardiac surgery? In between, there are more than 15 randomized trials. This has been published already 10 years ago by the Cochrane group, and the result was that transfusion with fresh frozen plasma was inferior to placebo for preventing patients receiving any red blood cell transfusion. So it was the opposite, that giving plasma increased red blood cell transfusion 2.6 times, which is not really a big surprise because plasma is not very effective to treat a coagulopathy. However, it's very effective to decrease the hemoglobin level by dilution, and then you give more red blood cells and not less. This is also quite good reflected in this cohort study from Fabrizio Monaco from Milan. That is just a cohort study where they change from packages to a ROTEM guided approach, and we see in patients with really major cardiac surgery doing open thoracoabdominal aortic aneurysm repair that the volume of plasma transfused was reduced from more than 2 liters to less than 300 milliliters. When we look at the incidence in the packages, 97% gets plasma transfused, which was avoided in 2/3 of the patients in the ROTEM guided group. And very important here that the decrease in plasma transfusion was also associated with a significant increase in pulmonary complications from 83 to 44%. And at the same time, there was a significant reduction in cost from 1,285 to 834 euro per patient. Also, when we look at the quite recent study just published some weeks ago in Anesthesia Analgesia, that's data from Johns Hopkins Hospital in the US, and they were looking at 48,000 patients undergoing surgery. This was nearly 39,000 patients undergoing cardiovascular surgery with a relatively small amount of red blood cell transfusion between 1 and 4 units. And the question was adding plasma to the red blood cell transfusion to be on the safe side and avoid bleeding was associated with a significant higher postoperative mortality, which was 36% higher. Also a significant higher incidence of venous thrombosis and pulmonary embolism, as well as DIC. So adding plasma, which might not be indicated in most of these cases, did not increase safety. It was associated definitely with worse outcome. So what is the alternative in this study? That was a sub-study from the Canadian Fibre study, which primarily compared the efficiency of fibrinogen concentrate to cryoprecipitate. And of course, in this study, some patients continued to bleed after normalizing the fibrinogen level. So they had a problem with thrombin generation. And then there was a choice to give 4-factor PCC or to give fresh frozen plasma. interesting, each unit of fresh frozen plasma increased the need for red blood cell and platelet transfusion, whereas every vial of PCC reduced the need for red blood cell and platelet transfusion. And PCC was not associated with any increase in thromboembolic events. And this is also in line with the recommendation from the European Association of Cardiothoracic Anesthesiologists again. So here the recommendation is in massively bleeding patients with coagulopathy, and the last paragraph is exactly defined what coagulopathy means here. We can treat this patient with an initial bolus of 25 units per kilogram body weight. In our algorithm, we are a little bit more careful, like here also in this paragraph, that in patients with a high risk of thromboembolic complication, that's nearly everybody, in cardiac surgery or undergoing liver transplantation or severe trauma, the recommended dose is half 12.5 units per kilogram body weight, or in our protocols 10 to 15 units per kilogram body weight. So how are the assays designed which should be used? They must be tissue factor activated, factor 7 dependent, and heparin insensitive point of care test as the XSTEM test for the perioperative monitoring and guidance of protamine complex concentrate. Finally, we look also at hypercoagulability. So here in the middle, we see a normal situation. On the left side, we see a significant hypercoagulability, but with normal fibrolysis, and on the right side we see the reverse situation, that's hypercoagulability with fibrolytic shutdown, which is associated with a very high incidence of thromboembolic complications. That has been shown already more than 10 years ago here that ROTEM can be used also to predict thromboembolic complications. So in adult, the best predictor is a maximum clot firmness in XSTEM higher than 68 millimeters, which has a sensitivity and specificity of 94% to predict thrombosis. The FIBTEM is not so predictive, and we know, of course, in cardiovascular patients, the platelet contribution is more important. Therefore, we treat most of these patients also with antiplatelet drugs. So how it's in a neonatal population, this is a study from Harvard University, and again, admission to the ICU, a cutoff value or XSTEM MCF higher than 69, in adults was 68, or a FIBTEM higher than 22, and in adults was 24, is a very good predictor for thromboembolic complications. And it also shows if we just, when there's bleeding, try to give everything, the incidence is higher. So what does the evidence tell us? There are a lot of guidelines. This is one of the latest, published in 2021 from the US group. And there is a clear recommendation for goal-directed transfusion algorithms based on point-of-care testing with viscoelastic testing devices, that this reduces the periprocedural bleeding and transfusion with a class 1 BR recommendation. And also these guidelines, of course, recommend the use of antifibrolytic drugs, the use of cell salvage, again, goal-directed transfusion algorithms, and they recommend against the prophylactic use of plasma because the evidence is quite high that this is more harmful than beneficial. This is just submitted to the American Congress of Anesthesiology for October this year in Philadelphia. It is a meta-analysis based on 10 randomized trials with 876 participants. Overall mortality was 7.1%. And we see that when we look at mortality, the risk ratio is 0.53, so nearly 50% reduction in mortality, which is also highly significant with a p-value of 0.02. And when we look at the subgroups, this was not significant for the TEC studies, but highly significant for the ROTEM studies. And this is in line with also a comment from Marta Petricevic that adherence to guidelines improves outcome in coronary artery surgery. So, of course, it's not enough to write guidelines. We should also implement and adhere to guidelines. And this is the last slide. I think the key message is if there's bleeding, keep calm. We should measure, and then we do a goal-directed intervention to stop the bleed. And at the same time, we should avoid the 4 T's, which is transfusion-associated circulatory overload, transfusion-related acute lung injury, transfusion-related immunomodulation, and thrombosis. And thank you for your attention and open for questions.
Thank you for that presentation, Dr. Gerlinger. Are you connected with us? Are you online?
Yes. Yeah, I'm online.
Hello.
I hope you can hear me. Hello.
Hello, thank you. And is there any question in the audience from the floor? Not yet. I would like to start, but I have to confess that I'm a surgeon, and it's a difficult subject for me to discuss about the ROTEM, because you see, in my practice, I'm a little bit prerogative, but it's the real life. ROTEM is so much complicated, and the algorithm attached to the ROTEM use. And the final answer is quite always the same: use fibrinogen. So, do you think that we always have to recommend the systematic use of ROTEM for the vast majority of our cases, or not?
No, I think the vast majority of cases are usually even not bleeding. I think, at least in our institution in Essen, also when we did 10 years ago, the first cohort study, and we published it in anesthesiology, also the question of the reviewer, why we are sure that we reduce bleeding and transfusion by using ROTEM when we only use it in about 25% of the cases. And my answer was, if there's no bleeding, usually we don't have to measure, because we don't want to treat numbers. We want to treat the bleeding patients. And of course, we also know in some patients, we have more coagulopathic bleeding. In other patients, we have more surgical bleeding. And what ROTEM, I think, can do is identify the patients with coagulopathic bleeding. I agree that in several cases, this is a low fibrinogen, but I think still around the world, to give too much protamine is also still an issue. So just having ACT available and it's prolonged after giving protamine, we don't really know is it prolonged due to a residual happen effect or already a protamine overdose, because protamine is a very sufficient blocker of factor V, so it looks like rivaroxaban, and it has also a similar effect, and it also results in platelet dysfunction. So one of the first steps can be really to avoid protamine overdose. And then again, if fibrinogen is low, yes, we should treat it, but again, the dosing should be individualized, because not everybody needs the same dose. And this is quite nicely shown also in this randomized trial in neonatal cardiac surgery. And what also is, I think, much too often given still is just the whatever 2 units of fresh frozen plasma. And we can show if there's no problem with thrombin generation, there's no indication to give plasma. So again, it's more like what we should avoid, what is not needed, than what is needed. And here it can be very helpful to avoid, let's say, over therapy in our patients, which is more and more evident that this is associated with worse outcome.
Okay, so would you agree with the message of prevention that would be don't give too much heparin and then protamine?
Yeah, definitely we should not give too much protamine. So usually we adjust the heparin dose that we get a sufficient ACT that we can go on bypass. But I think around the world, a lot of centers are still giving 100% of the primary heparin dose in protamine. And if then ACT is prolonged, they even give more. But most often in this cases, ACT is prolonged already due to a protamine overdose. And then we make the situation worse and worse, because we reduce thrombin generation by blocking factor V. And usually we stop antiplatelet drugs at particular ADP receptor antagonists maybe 3 to 5 days before surgery. But if we give protamine overdose, we block the achedonic ADP and thrombin pathway. So again, I think sometimes less can be more. And again, avoid over-treatment, I think, is very important in this setting.
Thank you, Dr. Gerlinger. I think it's time to move on for our group, and I want to thank you on the behalf of the audience to participate to that meeting. Thank you.
Okay. Thank you, and bye-bye.